Thank you, Giorgio. And nothing to disclose. So, the background as already, summarized by Giorgio is, the issue of brain metastasis is quite common in the thoracic oncological arena. The heterogeneity of clinical scenario can be certainly very high, even if in the vast majority of cases, regardless of the distinction between oligometastatic, oligorecurrent, or oligoprogressive diseases, mainly represented by multiple metastatic disease. Radiotherapy in this scenario certainly represents an important therapeutic option, mainly considering the technological development we got in the last decades. This means mainly stereotactic radiosurgery, but in spite of the advances in the different therapeutic options, of course, the prognosis of metastatic disease to the brain still remains poor. During the years, we are, of course, very familiar with different prognostic scores. You can see some of them in this slide, using very simple clinical factors like age, Prognostic status, extension of metastatic disease beyond the CNS, and the number of metastatic sites. And this is reflected by the RPA or GPA prognostic score. And we added also some specific informations coming from different histology. And of course, there are significant differences in terms of median survival times in the different prognostic classes if you compare, for example, breast cancer to non-small cell lung cancer. But within the same histology and the same tumor type, of course, there are important differences coming from the new world. Because, of course, within the non-small cell lung cancer family, there are important different subgroups. And if you look at this data coming from a recent paper focusing on the ALK rearranged tumors receiving TKI and radiotherapy, you can see a significantly longer median overall survival time. And if you put together, the same prognosticators like Karnofsky performance status, the absence of extracranial metastatic disease, and the use of TKI at the beginning or just after the onset of metastatic disease to the brain, you can see different clinical outcome according to the different prognostic factors. And when you compare these outcome to the original non-small cell lung cancer DS-GPA, of course, the value in terms of different median overall survival times is very, very important. So said, of course, the vast majority of patients suffering from brain mets mainly die from extra CNS metastatic disease, but nevertheless, the attempt to optimize tumor control in the brain is of paramount importance because, of course, progressive disease in the brain significantly and negatively impact patients' conditions in terms of quality of life and neurocognitive decline. So the possibilities in terms of therapeutic options concerning the loco-regional treatment are obviously correlated to the tumor-specific factor and patient-specific factors because, of course, simply choosing between neurosurgery or radiosurgery or whole-brain radiotherapy, the number of metastatic lesions and the site and the size of them, of course, is the most logical therapeutic consideration we are using. In a scenario like this, that is very common, of course, with, in the vast majority of cases, significant clinical symptoms, the traditional approach we are using is represented by the whole-brain radiotherapy. Whole-brain radiotherapy with the classical radiation schedules in terms of 10 times 3 gray or 5 times 4 gray, or a more American approach in a relatively longer fractionation schedule. But what we do know in terms of significant impact of such an approach in terms of overall survival and in terms of quality of life improvement till a few months ago, we certainly were lacking in terms of robust data in terms of level of evidence. A few months ago, this paper, and I am quite sure that you are very familiar on that, was published, the Quartz trial. In this UK and Australian trial, the researchers compare best supportive care to best supportive care plus whole brain radiotherapy with a schedule of 20 gray in 5 fractions. The results, as you can see, no significant difference in terms of overall survival in any of the different prognostic classes. And the same was also true in terms of no differences between the quality of life and in terms of quality. So said, this means that, of course, the consequences of such an information in the routine clinical work can be significant. And I guess that probably in many of your radiation oncological department, or you are probably modifying your traditional approach compared to the past, even if, of course, it is important to underline, for example, that in younger patients there is a significant therapeutic contribution coming from whole brain radiotherapy in terms of overall survival benefit. When we move from the multiple brain metastatic scenario to the oligometastatic scenario, you are all familiar with the focal irradiation approaches represented by what we call radiosurgery. Radiosurgery means the delivery in a very precise way of a single dose, aggressive biological dose. You can use different techniques, whatever you want, cyberknife, gamma knife, linac-based radiosurgery with invasive frame or with frameless radiosurgery. And this is one of the classical neuroradiological findings you can observe in treating with radiosurgery small metastatic deposits. And we also got, since many years ago, level 1 evidence in terms of positive contribution coming from radiosurgery added to whole brain radiotherapy in patients affected with oligometastatic disease, meaning 1 to 3 metastatic deposits. The overall survival benefit was limited to patients affected with single brain met in the original RTOG study. But if you look at the therapeutic contribution in terms of tumor control, this was also true, as you can see in this meta-analysis, for patients affected with 2-3 brain mets. The other important issue to be discussed is the contribution of whole brain radiotherapy in the context of adjuvant treatment after surgery for resected patients or after radiosurgery in case of oligometastatic disease, what we call adjuvant whole brain radiotherapy. From this point of view, we can certainly have significant information in terms of level 1 evidence saying the same thing. So, whole brain radiotherapy added to surgery or to radiosurgery gives us a positive impact in terms of better intracranial tumor control, both at local level and regional level, but without a significant contribution in terms of overall survival. And the negative scenario can be also represented by the potential neurocognitive decline coming from the whole brain radiotherapy, even if when you look at this EORTC trial information, the significant decline is certainly very limited and in the vast majority of cases just transient. But this, of course, has to be considered. And in the same way, it also has to be considered the fact that the neurocognitive impairment is certainly a multifactorial process. And just to give you another example coming from the breast cancer arena, you can see in this slide the significant neurocognitive decline and complaints in patients receiving chemotherapy compared to age-matched control. So this means that radiotherapy is not the only negative factor in terms of neurocognitive decline. But nevertheless, no doubts at the moment, and here are the results of another phase 3 trial showing the same scenario again. So whole brain radiotherapy added to stereotactic radiosurgery gives a benefit in terms of intracranial tumor control, but without a survival benefit and potentially producing a neurocognitive decline in patients. And this is the reason for which, as you well know, there are some recommendations in terms, for example, of ASTRO guidelines, the choosing wisely approach, and they say don't routinely add adjuvant whole brain radiotherapy to stereotactic radiosurgery for patients affected with oligometastatic disease to the brain. In the meantime, we are trying to improve the therapeutic window of our regional or local radiotherapy treatment in patients affected with brain mets in a different way. Specific dosimetry approach, radiosurgery replacing whole brain radiotherapy, and partial brain radiotherapy. So, the so-called hippocampal avoidance whole brain radiotherapy. Why to spare the hippocampal regions? Because, of course, the neurocognitive decline achieved by the contribution of whole brain radiotherapy may be related mainly to the damage to the neurostem cells, more important in the hippocampal region. So with IMRT approaches, we can certainly reduce the dosimetric exposure of such regions, and you can certainly improve the therapeutic window of your whole brain radiotherapy package, like shown in this slide. These are the results of the phase 2 RTOG trial, showing a less evident decline in terms of IQ compared to the historical controls when you were using whole brain radiotherapy without hippocampal avoidance. The other possibility is to extend the use of radiosurgery to a major number of brain mets. Till now, we were using a maximum criteria of 3 brain mets. There are some data coming from different countries in the world. This comes from Japan. You can see that in this experience, they were using radiosurgery alone with gamma knife, even in patients affected with 5-10 brain mets. As you can see in this paper, there are no differences in patients receiving radiosurgery alone comparing 3, 5, and 5, 10 brain mets. So you can certainly consider also this possibility as a further scenario to be investigated. But meanwhile, it is also important to remind you that in patients affected with a number of brain mets major to 3, 4, there are no specific data showing a superiority of dose intensification compared to whole brain radiotherapy. And this is an ERTC trial comparing the whole brain radiotherapy approach versus a whole brain radiotherapy approach with a simultaneous integrated boost to a number of brain mets, 2, 5, that is still ongoing. And finally, the other possibility could be when you have patients who had a recession of the single brain met, to replace the traditional whole brain radiotherapy to the treatment of the recession cavity alone. Because, of course, you can achieve a better tumor control with the use of radiotherapy, avoiding the negative effects of whole brain radiotherapy. And there are several centers dealing with such an approach. This scenario should be mainly restricted to the clinical research, because at the moment we don't have many robust clinical information at this regard. There are very preliminary data showing safety and efficacy in terms of stereotactic approach to the recession cavity. But of course, as previously said, the molecular heterogeneity of the non-small cell lung cancer family is also allowing us to do different choices in terms of therapeutic options. Because when you are approaching EGFR mutated patients, the possibility to replace the traditional radiotherapy packages with new therapeutic systemic strategy can be certainly true. From this point of view, just to give you an example of one of our patients in the clinical routine work, I mean, patients affected with 4 metastatic sites of the brain, one in the brainstem, plus other 4 in the MR scan, small metastatic deposits, asymptomatic in a patient affected with EGFR mutated non-small cell lung cancer. So in the past, no doubt the classical option was whole brain radiotherapy. Right now, we can certainly imagine to avoid and to defer eventually whole brain radiotherapy in patients without clinical symptoms in such small metastatic deposits. From this point of view, we are in the process of accumulating clinical data from the medical literature. This is a recently published paper, but this is just a retrospective series of a significant number of patients showing you the different clinical outcome of patients affected with oncogenic driver non-small cell lung cancer, in comparing the different approaches in terms of TKI at the beginning or the radiotherapy approach at the beginning and before TKI, represented both by stereotactic radiosurgery or whole brain. Of course, the clinical heterogeneity of this patient population and the retrospective nature of this experience doesn't allow us to get robust conclusion. But, of course, as you well know, there are ongoing studies try to compare the pharmacological approaches to the whole brain radiotherapy in such a specific scenario. But we are in the process of accumulating very preliminary information. 3 months ago in Vienna, this experience coming from China was presented in terms of a phase 3 randomized clinical study comparing in metastatic patients to the brain, the whole brain radiotherapy approach to the icotinib arm. And the results were a significant benefit coming from this drug compared to the whole brain radiotherapy, showing that, of course, these kind of things can be considered in the future in terms of replacing the old traditional approach represented by whole brain radiotherapy with a new pharmacological approach, of course, molecularly driven, even if there are many pending information in the from different point of view, efficacy of gefitinib and erlotinib, so other drugs, efficacy of these drugs in Caucasian population, and also the possibility to consider the role of such an approach not in multiple metastatic disease, but in more limited metastatic disease in situation in which we are employing focal irradiation approaches. But it is certainly true that in different scenario, the traditional whole brain radiotherapy seems to represent a sort of vanishing approach. Finally, the last possibility that is probably part of our clinical practice right now is represented by patients affected with metastatic disease from the beginning, receiving TKI, and presenting a scenario of oligoprogressive disease to the brain. In case of oligoprogressive disease to the brain, you can certainly use focal irradiation approaches like stereotactic radiosurgery, but this is just to tell you that at the moment, the information we have in terms of concurrent use of focal irradiation or also whole brain radiotherapy and new drugs in terms of safety are not too many, are not too robust. A few weeks ago, we published this experience in terms of a review of the data represented by the safety scenario with the concurrent use of new drugs, let's say TKI, whatever you want, including immunotherapy, and stereotactic radiotherapy to the brain or in the extracranial scenario. As you can see, the number of papers available in the literature is certainly very small, with small series as well. From this point of view, concerning the cranial stereotactic approach, the information we got are positive in terms of traditional drugs we are using in the thoracic oncological arena, because the major warning came from the melanoma arena with the concurrent use of stereotactic radiosurgery together with BRAF inhibitors. So, conclusion, of course, the optimal management of patients with non-small cell lung cancer and brain mets is an evolving paradigm. Patients with a limited number of brain mets have to receive focal irradiation, no doubts. There is, of course, a significant evolution of systemic therapeutic options, including the molecularly driven ones. The combination of brain radiotherapy targeted agents and different radiotherapy techniques is certainly to be further investigated within clinical trial, because, of course, as previously said, we do need robust clinical information in terms of safety. And this is just to summarize also in terms of potential discussion right now, the potential issue, the maximum number of brain mets eligible for focal irradiation, the role of adjuvant irradiation after surgery, and the discussion we had in terms of stereotactic approach on the recession cavity, the role of whole brain radiotherapy in terms of routine clinical use of hippocampal avoidance whole brain radiotherapy, the influence of quartz trial in modifying clinical practice, and finally, the concurrent use of radiotherapy together with new drugs in terms of optimizing, for example, the pragmatic clinical consideration we are doing in terms of washout, which is the scientific basis in stopping pharmacological treatment for, 1 day, 3 days, 3 half times of the drug or something like that. So thank you very much for your attention.